All right, everybody, welcome. Good evening, or whenever you're watching this, good morning. I'm Dr. Fort, the NICUDoc, and today I really wanted to talk about a topic that's actually really difficult to talk about, and probably one of the least favorite things that we have to deal with in the neonatal intensive care unit. Obviously, any unit, but when you're talking about the NICU, you're talking about babies. You know, this is an extremely difficult topic to talk about. So what is that topic? We are going to be talking about when do you decide, how do you decide to make that decision, to make the step towards discontinuing care and going towards comfort care, discontinuing medical care, going towards comfort care for sick babies that are in the intensive care unit. Giving the trainees all those NICU secrets, teaching the families, bringing you physiology and the latest evidence in management of NICU babies. Just having fun with it. And essentially, I'm really going to be giving my personal experience. Obviously, this is coming from articles that I have read, the training that I have gotten to this point, and obviously my own personal experiences as to how I've gone through the process of deciding this with the families and going through the steps. And we are going to be talking a little bit about when you make that decision, the actual moment, what things that we can do to really make this a respectful death. And I will be using that word a lot during this conversation because I think it's really important that we are direct when we talk about this. We are going to be talking about death, and it's an extremely hard topic to talk about, but we also want to be direct with our words. And this is actually something that needs to be done when you're having these conversations with the families. You have to use that word, as hard as it may be. So my disclaimer really is, again, I've had this experience on my end. I will say I've never gone through losing a child. I can't even remotely imagine what it must be for families. And again, my heart goes out to all those families that have lost a child. Again, especially because of my topic within the NICU, those families that have lost a child within the NICU. Again, I am truly sorry for that loss, but this is, I don't have any personal experience. So I'm going to be talking really about the medical part of things. Okay. Hello to everybody that's joining. I see a couple of friendly faces I know very well. So thank you so much for joining. So let's go ahead and jump to the topic. And again, how do we make the decision? What is that point? When do we make that decision? A lot of it, obviously, really always, but definitely in this case, should really depend on the baby, right? You're usually, this is something that you've got a very sick child, you've got a very sick baby, you've done a lot of interventions, you've done a lot of procedures, you've done a lot of the things that you can do from a medical standpoint, maybe even a surgical standpoint. And really, we haven't, reached the point of improvement, or obviously if things are not going well, then that's when you really begin as a physician and as a medical team, you begin to have those conversations that, again, are difficult, but you need to have those conversations. And those conversations really should happen within your medical team first. One of the things that a lot of families may not be aware is that when we're deciding whether we're going to approach the families, it's really not the doctor alone that's making that decision. Really, the physician or the team leader, if you will, has to approach the team to talk about this, to make sure that everybody is ethically and personally and emotionally feeling ready to take that step and to take that information to the family. So you, depending on where you work at, the type of unit, the type of NICU that you have, you really have to reach out to your team, your nurse practitioners, your nurses. There may be a respiratory therapist, and definitely, especially those nurses where the baby may be, the nurse may be the primary caretaker for that baby. There may be 2 or 3. You really need to reach out to those nurses, because a lot of the time, these nurses are emotionally invested. This may be a situation where a baby may have been in there for months. They know the families really well. They've established that relationship. For us physicians, obviously, we have that relationship. We know the families very well, but we're not right at the bedside. And so that's, I kind of always joke that the nurses are like the second mamas many, many times. And so you really need to approach the nursing staff to make sure. And actually, to be honest with you, a lot of the time, it's the nursing staff that comes to us to kind of talk about this situation. This is not something that comes out of the blues or anything that's surprising to most people. So first, again, you make sure your team is aware of this decision you're making. They're making that decision together. And then you look at the medical part for the baby. Is there anything that can be done beyond what's been done? Is there can you reverse any damage that may have been done? If you have a child who has a baby who has had, some severe bleeding into the brain and maybe progressing towards being worse, is there anything that you can do to stop that, hold that, if you will, and try and reverse that? Or is this damage that has been done so severe, either progressing towards or really showing no improvement? You need to make sure as a physician that the decision you're making is not clouded by your own biases. So we all are human beings. We all are, people. We've had prior experiences. So you need to check your biases at the door. Make sure that what you're trying to decide has no bias involved in this, whether cultural, whether prior experiences. You really need to make sure that that is taken out. You need to make sure that the patient is not on any medications that could be clouding the overall clinical picture of the baby. If the baby is fully sedated on 3-4 sedative medications, you still may have to make that decision, but you have to really decide whether you feel like the reason why the baby may be in that situation could be because of sedation. What you don't want to do is completely take off sedation just to prove a point, if you will. That's where you're having this conversation with the family, which we'll get to in a minute. But before that, you need to really, really make sure that this decision that you're going to make is, medically, ethically appropriate. Bias is out of the window. You talk to your medical team. And after that, once you really feel that you've made that medical decision, then you really approach the families. The one thing I will say before we get to the family conversation of this is that really the decision is made by the baby. A lot of the time, of course, we're approaching the families, but it's really the baby that has spoken to us, if you will, that has given us a lot of the information, has given us a lot of the evidence, has given us time for us to be able to get to this medical decision. And so that is really important to make sure that you're not rushing anything. There is absolutely no timeline to any of these decisions. A lot of it is based on feeling and evidence of how to approach. And again, from our standpoint as a medical team, really making sure that you have looked at all the medical part and that you've done as much as you can, and that this is not reversible. There may be prolonged damage, or that things are not improving. Okay, so again, I want to say hi to everybody that's joining. Hello. Thank you for joining this topic. It is a difficult topic. I tend to try and be a lot more smiley and happy and make jokes every now and then. This is a tough topic to talk about, but I think it's important because it is one of the things that's the hardest thing we have to do as clinicians within the NICU. And a lot of the times when I'm out there and people ask what type of doctor I am, I tell them I'm a neonatologist, I work in the intensive care. The first reaction you usually get is, oh my gosh, How can you deal with this? I'm sure the nurses and practitioners who are on as well understand this. But keep in mind, 99% of the time, there's a lot of happiness. There's a lot of sick babies or small babies that are able to improve, get better, and go home. So the topic today is definitely harder to talk about, and luckily it's fairly rare. We don't tend to deal with a lot of deaths, but it is an intensive care unit. So obviously this topic does come up. Okay, so let's move on. So we talked about sort of making that decision and one final thing before we move to the parent is understanding if it's better to make that decision at that point, or where you can have sort of a peaceful transition to death, or whether you want to wait until there is some medical reason, which unfortunately could lead to a code or a very chaotic situation. So that's also something you have to take into account. If you've done everything, if it's irreversible, if you have a moment where you don't think things are going to progress, but you also don't want to wait last minute until things are so chaotic that this is very disturbing and very difficult for a lot of families, more so than the decision that to discontinue, but you have so much chaos that it's very hard for them to watch. That's another moment where you might need to now approach the families. Keep in mind, first conversation does not mean that you get an absolute decision at that point. You're not going in to talk to the families usually to get an answer. The last thing you want to do is walk in to a family room with the idea that you're going to walk out with a perfect plan of what to do and with an answer, a yes, no answer. This is one of those things. It may take 2 to 3 weeks for the families to get to that answer or not. The baby a lot of the times makes that decision for the medical team and for the parents. But there is no timeline to this, and this is what's really important, okay? It's a balance between the ethical too. What we don't want to do, and I talk to the families about this, is cross an ethical line, cross a line. I always tell the families that I'm going to approach them when I feel like we are hurting the soul. Because as physicians and as a medical team, you can do so much to the body. You can put lines, you can add 20 medications, you can do a lot of procedures, you can do all these things. If I feel like we're crossing a point where we are hurting the soul, and again, every person's different, whether you feel it's the soul, whether it's the karma, call it what you will. I call it the soul. When I feel that the interventions that we are getting to are hurting the soul, that's when I approach the families. This is when I have to have that conversation with the families. So let's get to the conversation with the families. So in my experience, I've been doing this. I've been a physician since 2006 and a neonatologist, a pediatrician since 2009 and a neonatologist now. This is on my 6th year, and I've unfortunately had obviously several situations where a baby has died. The one thing that I've at first was surprised with, but I've learned after having these conversations many a times now, is that you can't assume that the families haven't thought about it. And in fact, I will say that I feel like most of the times the families have thought about it. And I've reached a point now where when I come and approach the families, I assume actually that they have thought about it. And sometimes we'll even say, you may have had these thoughts, even though you don't want to express them, you don't want to verbally talk about them, maybe even with your family, with your partner, but you may have had these thoughts, and I want to now bring them to light. Let's talk about this. So that's the one thing. It's don't assume that the families, that this is going to be a huge shock for them. Really, kind of do this together, but assume that this may have been something that they have thought about, even though it might have been unconsciously. So first thing you want to do is really schedule a family meeting. Again, unless you're in an urgent situation where a baby, a child may be in dire straits and maybe really getting sick very, very quickly, you really want to try and do this stepwise as best as possible. So you want to schedule a family meeting. have a coordinator, have the palliative team. If you have a child psychologist present, have the primary nurses there, people that the family may be akin to, may be able to use a little bit of support within the hospital. Obviously that family, I know right now with COVID it's very difficult. Normally would say that family would also want to bring some support system with them, whether it's just a spouse, significant other, another family member. We usually have 2, 3, 4. The other thing not to assume is that they actually want a big room of people. Some families actually just want to talk to the nurse and the doctor. We can't assume that it can be crazy intimidating. These conversations, when you're sitting across the table, you've got 10 people looking at you, and sometimes it may be really overwhelming. So, don't assume again, and this is where you ask the family, I'd like to have a family meeting. Let's talk about how best to do this for you. And so you schedule that family meeting and you set up the expectations. So-and-so, we have been, doing a lot, to baby X, and, we're really, struggling right now. We're having some issues. We've got all these medications. Things are not improving. In fact, things may be going in the wrong direction. I think it's really important that we have a family meeting. I'd like to go ahead and schedule that. Let's set up how we do it, when we do it, and so on and so forth. So you're already establishing a little bit of the expectation that you are going to be talking about these things and that you are worried. So it just kind of begins to, you place that seed, if you will, into the family that you are going to be talking about things that are very serious. And so a lot of that is important to set the tone for that meeting without directly putting a title, if you will. You don't want to label anything. You don't want to put a title. Again, we can't assume anything with family, so you don't want to walk in and immediately assume, and you don't want to put a title and say we're going to be talking about how we're going to discontinue care. That would be a big, huge no. At the end, I am going to go through some phrases and some words of things that you should not say in these situations. I'll stop real quickly again just to thank those. We've had several people coming in. I really appreciate always you guys supporting and joining this conversation, this live tonight. And again, as usual, if you guys are really liking this, go ahead and hit those hearts. Let every other people know that we're having this conversation. This is difficult to talk about, but I know that families really appreciate sometimes. And I've been asked many a times, how is it that you think about these things? So I thought, let's make a live. I also want to put out there, if you guys have questions, please, there is a Q&A button, that little question mark at the bottom. Go ahead and put that if you have a question on there, or you can just add it in the comment section if you have a question about anything that I'm saying. I'm just going to keep on, I have a little agenda to talk about, but I can break it at any point. So if you guys have important questions, I'll stop a little bit and address that question too. Okay. So what I usually do is, as I mentioned, schedule a family meeting. Once you have the family meeting, you don't want to go in with an agenda. Last thing you want to do is go in with a prepared spiel. You don't want to go in saying, okay, this is what I'm going to talk about. This is not a test. You're not taking a driving test. You're not taking a book test. You really want to go in. What I usually do is I would say maybe 3 to 5 phrases that are what I call the one-liners. Basically an introductory phrase, if you will, or introductory sentence. Beyond that, a lot of it is really getting a feel for the room and getting a feel for the family. So I may, in a situation where we have a child who's not improving, I have sort of a one-line spiel to come in and say, we're going through this difficult time and, with so-and-so and things have not been improving. We've got these issues. I try to keep the medical to a minimum. You're not there to discuss the medication they're on. You're not there to discuss necessarily the MRI. We can answer these questions if the parents are there, but you really want to keep your discussion to what the focus of why you're having that family meeting. But you give a quick, brief introduction of where's baby X is at, and then you lead to the why is it that you are having this meeting. I think it's really important to find out, I really want to hear your thoughts of where you think or how you think, you know, baby X is doing, your baby X is doing, and what can we do, where are we going to go, let's talk about this together. So you have a quick 1 minute, 1 sentence spiel on the sort of introductory spiel, not the whole spiel. And then get a feel for the room, get a feel for where the parents are at. You know, at that point, it may come as a huge shock to them, or they may actually look at each other and say, yes, we've been thinking about this, we've been talking about this. I've actually been through the whole extremes of situations where I've been surprised both ways, where I thought a family wasn't ready, and on the contrary, they had been talking about this, and on the other side, a family that I thought they had really discussed this, and it came as a big shock. So you'd never know, and you shouldn't assume what you're going to see when you walk into that room or what you're going to get. So it's a little bit like dancing with the family at that point, really trying to understand where they are. This is what's difficult about these conversations. As physicians, you're so used to having a perfect plan of how you want to do things. When we're running a code in a situation, we know we have an algorithm in our heads of how we go in, what medication we choose, you know, how we're going to sort of drive this to the point where we can, you know, get out of this bad situation. Here, it's very tricky. It's basically, it's sort of like rock climbing. You go in, you have to get a feel for where you are. And if you feel like you're going to a certain situation and you're going in a direction, in one direction, and you realize, oh, wait, the family's so not in that direction. We need to back off. We need to, let's move back to another situation, another direction, I should say. Then you have to do that, and you have to be super flexible. Remember, the goal of that meeting is not to get everything out on your agenda and not to get an answer of a yes, no answer or a perfect plan of how we're going to discontinue care. The goal of that meeting is to have that first conversation with the family of where you think you are, where are they, and if they are advanced, if they have really thought about this, begin to help them with a plan of, you know, of how we're going to do this. And you can talk now more detailed, more specific stuff. So that first meeting is really important for you not to go in with an agenda. The meeting is really for you to be a listener. And again, depending on where the family's at, you want to go in and be sort of, use your one-liner, use your one sentence, and then listen. Listen to where the family's at. Now, again, family may not want to say anything. They're taking this all in. And so you can't, again, assume where the family's at, but the goal is for you to be a listener. Let the family talk to you. Let them tell you where they're at, what their fears are, what their thoughts are. And if they really have thought about discontinuing care, they may have a plan of how they want to do it. And so you really want to be a huge listener when it comes to that. As I mentioned before, if the family agrees, if the family wants, you really want to listen. You really want to have your team there present, including palliative care, social work if they can support, psychology if you have psychology, a psychologist in your team. You want everybody to be there to not only listen to the families but really be able to support. We're minimally trained in a lot of the other areas like psychology. We have some very little training in child psychology, and so I always have my child psychologist there present to be able to support me when the family is asking something that I feel really needs her expertise. Same thing, if there is something else that can be done from a palliative care standpoint, then really the palliative care team can really add so much information, and that way the family feels, first of all, that I'm not the one making the decision, but really there's a whole team. This, baby X has a whole team caring. And we always say it takes a village to care. It also takes a village to continue and have a good plan at the end of life. So I'll continue by talking about, when you have this meeting, and if you really feel like the family has reached a point or is getting to a point where they would like to get more information or proceed with the idea that, they have also thought about, they want to go ahead and discontinue. If you feel like that is the appropriate moment, then at that point you can really begin to have the discussion of how to do it, how to go through the process. And this is where, if you have a child who has a breathing tube, you want to begin to enter the specifics. If you have a breathing tube, do you want us to remove the breathing tube, prior? Do you want us to discontinue medications prior to you to the baby dying? Do you want to hold your baby? And again, always don't make any assumptions. Yes, the great majority of families want to hold their babies at the time of death, but I've also been in situations where the families don't even want to be present, and we are not to judge those situations. This is something that on a personal level, and we talked about this at the start of this Instagram live, from a personal level, you have to completely separate yourselves from both your culture and your biases. Is that something that I would choose? I don't know. As I mentioned, I've never been in that situation. So if a family chooses not to be present at the time of death and to go ahead and discontinue and have somebody hold, we do still offer that. We still have nurses and other folks that allow the babies to have a respectful death, but don't assume. And so this is where you ask the family, how do you want us to be there? Do you want to take pictures? Some families, we do offer that service in our hospital. I think most hospitals offer sort of a bereavement package where you have essentially a box, if you will, where you can do footprints or handprints. You can, they come with a little dress or a little, clothes that you can close them after death or before death, and you take pictures, you take professional photos. So again, this is, every family decides to do what they feel they need, and you're there to support, not there to judge, definitely not there to tell what the family should do. Now, a lot of the times you're there to give information. A lot of the times the families don't know what to do or what to expect. So you are there to give information. You don't ever want to compare with other families, but you can break up and say, we have this service, and some families have opted to have a clergyman or a priest or whatever culture you have come in and pray. This is something that they will remember for the rest of their life. So you do what you can to make this as best and comfortable a moment as possible. Thank you. I want to mention a couple of Philip Davison there. Thank you for what you do. It takes a lot to do your job. I really appreciate it. And this is a tough topic for me because it is one of the least favorite things that we do in the intensive care unit in the NICU. But again, it is part of the job. But that doesn't mean that you can't do it right. And I was just about to get to that. I will say that if one thing in my experience that I've learned is that there is something that I call a beautiful death. In a perfect world, you would love that no baby would die if we could, allow every baby to live. And again, I'm not going to get to the ethical, cultural, or religious of this, but we know it happens. But that doesn't mean that this has to be a horrible, traumatic moment. And you want to try and make this as best as possible respectful for the baby. You want it to be as beautiful and as calm and as angelic as you can make death to be. That doesn't mean there's not going to be pain, there's not going to be sorrow, there's not going to be a sense of loss for the families, and that's where you also respect that as well. You can't, again, you cannot assume how a family is going to react. And there's a whole gamut within these moments. There's a whole range of reactions from the families, from anger to, I've actually had a dad even laugh, and you don't join in that. You know that this is a reaction, you know that this is a mechanism, and you really respect that. So this is, there's no way to know how a family is going to react, but you can make this as best and as beautiful for the baby as possible. And a lot of the time, you talk about this with the families beforehand. A lot of the time, the families don't know what to expect, and they see death that you see on TV, which tends to be over dramatic, over traumatic. And a lot of the time, actually, the death of a baby can be very peaceful. Again, that's not to say that you don't have all the emotions within the family, but I mean the moment itself. If you look at the moment within a bubble, it tends to be actually very peaceful for the baby. And that's what we aim for, to try and make this as beautiful, as peaceful, as respectful to the baby and to the family. So let's talk about actually now going through the process of discontinuing care. If the family's made the decision, how do you go through the process of comfort care, discontinuing clinical care, and going through comfort care? So it's one of the things that I always talk to the families about even before we get to that. So this may be in that family meeting we had, or several family meetings, or just a one-on-one after that at some point, is that I tell them that I want you to give me a buzzword or a buzz phrase that tells me that it is time. Last thing you want to do, and there's research on this, a lot of the families don't ever want to make the call, the phrase, the word, don't want to use the word death or it's time or let's do this, because that association, there's an association that it was their hands that caused the disconnection. And I hate to use that word, so that's probably the last time I'll say that, but that they caused the death for their baby, and they take that on for the rest of their lives, that feeling that it was mine, it was my decision that caused all this. So a lot of the times I really try and bring that back to the families beforehand, to let them know that honestly the decision is the medical team, but we are going to do it respectfully together, and that I'm going to allow you to make the time where you feel you're ready. And that's kind of crazy because no parent is ever ready. But I want you to tell me when you feel you have reached a point of readiness. But ultimately, I tell them, give me a phrase. And then it's going to be up to me and my medical team to actually go through the process, and it won't be immediate. So families may choose something as simple as I'm ready now, and if they want to use that, that's fine. I've had families say, Big Ben, anything completely unrelated to death. I had a family, actually, do you remember this, talking about the meadows. And they really liked the image of the baby going towards, the beautiful meadows, and so that was their word. And so we had established a beautiful relationship, and I knew the baby for a long time. And when it was time, they basically just said, Dr. Ford, meadows, and that was it. And it wasn't done immediately at that point. I don't want them to associate that word or that sentence to immediately going through now the process of discontinuing care or going into comfort care. I basically would, come back to my medical team, talk to them. You want to do it soon thereafter, because obviously if at that point the family has reached a moment, you don't want to be waiting 2 to 3 hours, but you also want to get them to understand that the decision is really coming on the medical team, so that they don't feel like they're going home with that and holding on to that as that they made the decision to discontinue care in their baby. So again, usually I let them use or give me a phrase or a word. I let them know that when we talk about comfort care, we're talking about really making the baby comfortable in the last minutes of life. And we can do that with medication. You know, a lot of families fear that we give medication to stop the baby's heart or to, you know, stop the baby from breathing. Well, that's illegal. That doesn't exist, not in this country. And I think there's only 1 or 2 countries in the world that allow that. That's called euthanasia. We do not do that. But at the same time, you don't want a baby to ever suffer or feel pain in the last minutes. You want this, as I mentioned before, to be as comfortable to the baby. And so we are allowed to give pain medication and to give anxiety medications to help the baby not feel pain, first of all, and not to feel anxious, not to feel distress. You want them to, again, be as comfortable and have as beautiful of a moment as you can within, you know, the whole realm of death for this family. So we are able to do that. When you are going through the process, you have already aligned and you have already had a mental conversation with the families as to the steps that you want to take to allow this baby to die peacefully. And so now it is time for you to take those steps. You don't deviate from that unless, again, the family may ask something a little bit different. But if the family has given you their wishes, you try and sustain to those wishes, abstain. You want to try and follow those wishes as best as you can. If they had wanted the tube to be out, you remove the tube. You give them that time. You give them that, you know, if they want to hold the baby, you give them that time to hold the baby. So you really, this is a time now where you go through the process. Make sure that before you go in there to initiate comfort care and go through the process of discontinuing medical care and allowing a baby to die peacefully, that you remember. You've written this down hopefully somewhere in the chart so that you remember. And if it's not you, then you pass that on to your colleague that may be taking call for that night, and unfortunately may be happening, you know, after your time. That's where you really have to, you know, make sure that you follow the family's wishes as best as you can. With that, this is a time for the family and a time for peace, a peaceful moment for them. So we don't need observers. We don't need a ton of people to be standing there looking at what's going on, especially those that have not been involved. Usually this is a time for very family-oriented situations. This is a time where you may have the primary nurse, you may have a physician or a resident or a fellow, somebody who may have been taking care, who wants to be present, and that's where you also ask permission. You know, is it okay if I stay? Sometimes once you've gone through the process and you make sure that that everything you can do from a comfort care standpoint is done, and the family may be holding, then you walk out. You respectfully excuse yourself, letting them know, this is time for you. I want to give you time. We're going to be right outside if you need anything, but, you know, please take this time with your family and your baby. So this is not a moment to bringing people who've never seen this and want to know what death is like. This is not about curiosity. This is, again, about giving the family that respectful moment at their baby's time of death. With that, speaking of time, you can't rush this. This is one of those situations where you do not look at your watch. If there's something going on, then you don't do it in that particular second. You really want to give the family time to be able to spend, to say their goodbyes. If you have a special bereavement room, you may move that family to a bereavement room where they may be there for 3, 4, 5 hours. You know, depending on the hospital, sometimes they have, you know, palliative care will bring in some food so that they don't have to worry about going to lunch or feeling hungry. You want to make them as comfortable and respect their time as best as possible. So again, you arrange these things. If your hospital doesn't have these are things where you begin to have conversations with administration so that you can develop this, whether you do it through part of a QI project or so on and so forth. But you really want to give this family as much as you can in this extremely difficult moment, and make them or allow them to have as much of a peaceful moment as you can. When I've given them some time to spend, and obviously, as physicians, we have to call time of death. This is, policy. This is something that we have to put in their certificate. This is something we have to do. But does it really matter that you know exactly the absolute moment when the heart stopped? No. This goes back to being respectful and having and allowing the baby to be respected as well. And so you may listen before you leave. You hear a heartbeat, you walk away, you give them time, you come back after a little bit. And that's when you listen to the heart. And if it's still there, you ask them to come back. You give them enough time. You don't need to be coming in every minute. You give enough time for them to have time with their family, and again, respect that time with their baby in a really difficult moment. This is also a time when this happens where I begin to dissociate my conversations. I dissociate the name of the baby to the body. And again, this is my own personal way of approaching this. You don't have to do this, and if you don't believe in that, that's fine. But I usually, after going with, baby X and calling baby X him or her by the name and all this and that, when I reach a point where I'm approaching now to call time of death, or I'm approaching and see that their baby is very close to death or may have already died, at that point, I now begin to talk about the body. And I don't say baby X is gasping, or baby X is twitching, or baby X's oxygen is okay. I basically now at that point begin to talk and use body terms. And I may say, the leg is twitching. The diaphragm, which is the muscle for breathing, is beginning to have some spasms, as opposed to using the baby's name. And that way, again, what I'm trying to do is allow the family to understand that, again, for that baby, and this is a cultural thing, for that baby, that soul may be going up to heaven or whatever you believe. If you don't believe in that baby's essence, if you will, karma, whatever it is that you believe, is no longer there, and we are left with a body, with an anatomical, muscles and bone and cellular structure. And I think in dissociating, that allows the families to begin the process very quickly, to begin that process of knowing that their baby has left. And now we are basically holding a body. And I've learned that tends to, when you reach that point, they tend to understand that a little bit better, as opposed to saying, little XYZ is gasping. We basically now talking about the diaphragm having contractions because there's some acid level that's building up in the body. And again, I feel like that helps some families to begin the process of knowing that, okay, this is no longer my baby boy or girl. This is now, anatomical. This is now a body. So again, you can imagine none of this is ever easy. There's no perfect way of doing this. One of the hardest things sometimes is when you do, as a physician, you go on call. I've been in a situation where I came on call, and really within 5-10 minutes, a baby that had been planned, everything had been planned during the day, passes. At that point, that baby dies, and I had to go in with the family. They didn't know. I hadn't built that relationship with them. They didn't know me, and those are very difficult. But again, that doesn't mean that you can't walk through these steps to help them through this. At the same time, those families that I have a wonderful rapport with, that I know really well, I'm with them. I'm with them to the last second. And right now, no, not with COVID and everything, but I've been with families where we have been holding hands, we've been praying, we've been hugging, we've been crying, and it's just a human moment. This is no longer about medicine. There's no book that prepares you for something like this. You can't read it. You can't prepare mentally, physically, emotionally for something like this. But it does affect us. And again, I'm not saying to the same level that it affects the families. I can't even imagine that. But it affects us as people. And so, whether you have that rapport or not, usually after a situation like this, we do a debrief with the families, with the staff. So with the nurses, with the respiratory therapists, with other folks, we debrief, we get together in a room and just basically talk about, how we're doing, how we felt that those last moments, those last minutes for the baby were, and could we have done something better? We definitely want to always strive for improvement. So could something have gone smoother, or was this as perfect as you could make it in a very difficult situation? And then personally, I usually give myself some individual time after all this to pray and pray for the baby. And again, every person is very different. So this is now up to you and your culture, what you would like to do. So I'll mention some things not to say. We're sort of, we've got about 5 or 10 minutes. And if you have questions, please feel free to add them to the comment sections. I really appreciate all I see a lot of support and people coming in. So I really appreciate that. If you have questions about this, if you've had some personal experience with this, either from either side, feel free to comment. Let me finish by saying some of the things, these are some things that you definitely don't want to say. Again, you want to be open, you want to be you want to be personal, but you don't want to put your professionalism down. You don't, this is still the moment for the baby and for the family. So, you still need to act, professionally. Does that mean you need to be cold? Absolutely not. Like I said, I mentioned already before, I've hugged and held hands and been with families in this really difficult time. I've been accepted just like a family member in this difficult moment. But you still need to understand and be professional about this. So things you don't want to say in these situations. You do not say, "I understand how you feel," ever. In these situations. In a difficult situation, you never do it, and never ever in a situation where you are dealing with a baby who's dying, even if you've had a baby within or a family member die. Every person is different. You cannot know how they're feeling when that's happening. So you really, really avoid that phrase. Last thing you do not want to say is, "He or she is in a better place." A lot of the times we're nervous, especially when you first start out as a clinician, or you don't know what to say. You've seen it somewhere, somebody said it, you saw it in a movie, and you don't think about it, you just say it. "He's in a better place, she's in a better place." Not for a lot of families. Not for a lot of families. They would love their baby to be there with them, not anywhere else. So that's a big no-no. You don't want to use, that phrase, because again, most of the times people don't consider, dying, going to a better place, So unless the family has acknowledged that, unless the family is saying this, then you can go ahead and acknowledge that if that's really how you feel. A lot of this, again, is your personal feeling, keeping it professional, but just be you, be yourself. You don't want to say, "You'll be fine in time. Don't worry, this too shall pass. It'll be okay in a few weeks, in a few months, in a few years." You don't know. They are families. I was actually received a message from, or reading, I think, a post or a message from a family who 5 years later, after their loss of their baby, was still feeling that loss. You don't know how a family is going to feel. Some families 6 months later, they may be okay. But you can't say that this too shall pass. For many families, it could be 20 years and they still remember vividly that night. It doesn't matter if the baby lived 3 minutes or 3 years. It's still something that stays within that memory. And then the other final thing is, don't compare with other families. This again, every family is different. And you don't want to say, oh, I've been in a situation like this with another family and this is what they wanted to do. You can help and you can educate and help them through some of this process, but you really don't. Just like you try, and sometimes it pops out, but you don't want to compare your kids. Well, this is a very, very, very dire and special situation where you really do not want to compare families and say, this is what they did, would you like to do something like that? You can give options, but try not to have a comparison with families. So okay, so I don't know if anybody has any questions. Again, I'm happy to discuss anything. It's a difficult topic, and most people don't want to talk about this, but unfortunately in the intensive care unit, it does happen and babies do die. But there are ways of doing it, and there are ways that we can make it, like I said before, you make it a beautiful death, make it a respectful death for the babies, and help the families go through the process of bereavement and through the process of trying to heal through this. It's also very difficult for us, as for the medical team, the nurses, the practitioners. We also feel a loss. It is so hard for me sometimes. The next day when you round, there is a new baby in there. One of the craziest things that happens is when you lose a baby and then immediately you get called to a delivery of a baby that does amazing, and you have to change your face and you have to change your emotions, because for that new family, it is their moment. So you smile and you congratulate them, but you can imagine on the inside, your heart is going, not knowing what to do. So it affects us too, and mentally too. So you have to recognize that and talk to other folks if you're really having trouble with that. I will also add resources. I'm going to go ahead and put a post either tonight or tomorrow with some resources for families who may have gone through something like this, or maybe going through something very difficult, that you can go into and read about this already. So there's a few questions. So let me see. Perinatal care ND, hello sir, how are you? Thank you for joining. It says, does a meeting with the NICU team about a postnatal lethal finding help with end-of-life care discussions later on? That is a great question. And we have had, if I'm understanding your question, what I've had in the past is actually had a post-mortem. So if they did an autopsy and we were able to find something on the autopsy, it would actually help for future pregnancies. If they were trying to decide to have other babies and they had a lethal genetic defect, it would actually help them with making that decision. I think your question specifically is more about does a meeting with the NICU team about a postnatal lethal finding help with? Yeah, so this is something that we sort of discussed a little bit earlier, I think before you came in, which is you really do want to have family meetings, and you want to have them several times. And yes, is it easier for the family to make a decision with a lethal disease or a lethal diagnosis? No, it's very difficult, especially sometimes because you have these lethal genetic diseases, but the baby looks amazing. Sometimes you have these babies that they have a genetic problem that is very visible, and the families a lot of the time are quicker to make that decision because they can see it. It's something physical. But a lot of the times you have genetic defects where the babies don't look that much different from any other baby. And so that's very difficult for the families to, make a decision if they need to, if they're on a breathing machine and they have to make a decision. But yes, having these meetings definitely does help the families to understand. And again, as we talked about, it doesn't have to be one meeting. It usually isn't. You really want to have multiple meetings before the family makes that decision, makes that choice. We do have a fetal care center, as I think you're aware, and we we do meet with the OBGYN, we do meet with the MFM to discuss, lethal diagnoses. And yes, this, you need to have that in preparation for when the baby is born, if the baby has a lethal diagnosis, you want to have a conversation, just like we've talked about making a plan. If a baby gets sicker, this is where you make a plan for the moment of delivery. How much intervention are you going to do? How much do the parents want you to do? And you have that discussion. And again, as I mentioned earlier, you can't assume anything. There are families that still, want a day or two with their baby, and they request for us to do as much as we can. And again, always respecting the baby too. The baby has rights and decisions too. So, you don't, as I mentioned before, if you're doing a lot to the body and you're now crossing that line and hurting the soul, then that's where it gets to ethical issues that you have to really know where's that line. Where's that line from a legal standpoint, but more importantly, where's that line from a personal, cultural standpoint, and have those discussions before it happens. So thank you for that question. Okay, unless anybody has any other questions, I'll just closing statement. If anybody has any other questions, please go ahead and put them in the comment section. You can also DM me anytime for any of questions about what we talked about today. I'm gonna go ahead and put this on Instagram TV. I'll also prepare and put this on my YouTube channel. I appreciate everybody who's come on, very attentive. Again, this was a tough topic to talk about. I usually tend to be much more lighthearted and making jokes if I can, but this was a topic that I think was really important because it is something that we have to deal with. One of the things that I really, really don't like about the NICU, but I also think it's something that we have to talk about because it does happen. So thank you so much for your time, your attention. Really appreciate it. Have a great evening. If you're watching this later, morning, afternoon, anywhere in the world, thank you for everything. Again, please feel free. I have a YouTube channel. If you look at, the NICUDoc, go ahead and, check out my YouTube channel where there's information about NICU and babies in general, especially now with COVID. I got a lot of information there. Please subscribe, like and share. Same thing for Instagram. If you haven't done so already, join me as I post stuff every day. And every Sunday, I go ahead and post the agenda of topics for the whole week. I focus on one topic Monday to Friday for physicians, clinicians, and also for families. So thanks again for your time. Really appreciate it. Have a great evening. Bye-bye.